enter the room, if you can use the chat to let us know where you're from. We'd love to have been in person and actually do the shout outs, but the chat will do fine. So as you enter, welcome and let us know which part of the city, which part of the country, which part of the world you're from. Oh, Roberta, okay. Welcome from PA. Well, I'm just going to say that I'm from New York City. I'm not going to use the chat. Most people know that I am, but I'm just going to give the Big Apple a shout out. If you're entering now, if you can enter where you're from in the chat, and we will be starting shortly. Just another minute. It's great to know that you're in the house, Roberta. Thank you. So hi, everyone. I know you are entering and you're putting in the chat where you're from. Ada in Ohio, welcome. I'm Desiree Walker, and I am the YSC board president. I'm a patient advocate as well as a health educator. And it's great to see Florida is with us. Washington is with us as well. South Carolina, okay. Keep it coming. We're looking forward to welcoming each and every one of you. Today, I'm thrilled to share the stage with Dr. Vivian B. YSC is pleased to welcome her to discuss disparities in the era of COVID-19, confronting vaccine inequity and bias. Okay, Georgia and Virginia as well. As you know, there's always housekeeping rules, guidance. So we're using the chat to say hello and to say where we're from. But when it comes to the questions session, please use the Q&A box only for your questions, and that's at the bottom right-hand corner of your screen. The session is being recorded, and it will be made available later. And as you know, we always want to get the feedback from you. So there will be a link to a survey for this particular session after the event, and we ask you to take a few minutes to complete it. We really hope that you will take the time to give us the feedback so that we can continue to create impactful and meaningful programming for you. So without further ado, I would like to introduce Dr. Vivian Jolly B, who is the Section Chief of Breast Surgical Oncology in the Department of Surgery for New York Presbyterian Brooklyn Methodist Hospital. Dr. B received her master's degree in biology from Drexel University and her medical degree from Morehouse School of Medicine. She completed her training in general surgery at the Medical University of South Carolina and a fellowship in breast surgical oncology at the University of Texas MD Anderson Cancer Center. Dr. B is a disparities researcher, an educator, a community outreach leader, an entrepreneur, and if that's not enough, she rounds it out as being a best-selling children's book author. So please join me in welcoming Dr. B. Thank you so much.
Thank you so much for having me, Ms. Walker. You know, we have collaborated on a couple of events. You spoke at one of my events last year dealing with breast disparities. You know, this is a passion of mine, and I am thrilled to be here. I really want to take the opportunity to address what we came here to talk about. As we know, the past, oh gosh, what is it, 14 months or so, our country has been ravished, and our way of life has certainly changed. And so it's important as survivors to understand the foundational pieces of what has happened and really where we are currently and where we are going. And so I'm just going to have shared my screen, give a brief presentation discussing the COVID vaccine. And I always like to start with some educational slides so that we're all on the same page. As we know, the SARS-CoV-2 is the name of the virus that we all learned about early last year, and COVID-19 is the name of the illness that caused the virus. And over the year, in pretty much the beginning of COVID's introduction to us, we learned that it can be transmitted via airborne or also through droplets. And so that's where the recommendation came to wear mask and sometimes eye covering. So let's talk about the vaccine and how it works, because I truly believe that with education and knowledge, it's power, right? And so the more that you know about the vaccine and how it was developed, the more confident you can be in receiving the vaccine. So a vaccine works by showing your immune system basically a piece of the virus, essentially a mugshot. And I put this picture here to help illustrate that point, that there's a mugshot and your body sees it and takes a picture of it, and then it creates antibodies such that when it sees something familiar to this mugshot, i.e. the SARS virus, that it's ready to attack based on the antibodies that it was able to produce. And the two vaccines that we are going to talk about today are the Moderna and the Pfizer, and they are both messenger RNA vaccines. And just a little bit about the messenger RNA vaccine. It's a temporary genetic material which is injected into the vaccine, and it contains instructions for making harmless spike proteins. And after those spike proteins, as you can see, I was trying to get my pointer on the screen, but it's not working with me. But you can see in the lower right-hand corner that the messenger RNA sort of gives instructions to produce this spike protein, and then it's displayed on the cell. And then your body produces this army that we call antibodies. And those antibodies, or the army, form such that when it sees the same spike protein on the coronavirus, it is then able to attack. So you're basically equipping your body to just be geared and armed. Now, as I've talked in the community about the COVID-19 vaccine, some of the common questions that I received are, well, is the vaccine safe? I heard it was made too quickly and shortcuts were taken. And of course, these are important questions, particularly for my cancer patients and cancer survivors, because we know that you can't really take a hit. So we want to be sure that when we introduce something into your body, that it is effective. Well, the COVID-19 vaccine is based on actually decades of research from similar vaccines, and a lot of people don't know that. So early 2000s, we actually had a similar virus that we were able to start doing research on. And so a lot of that foundational work was already laid. With developing the vaccine, remember, this was a pandemic that affected not just the United States, but globally. And so with that came global resources where manufacturers and governments could work together to overlap and speed up the research project. All of the same safety standards and expert reviews were used in all of the vaccines, and that's very important. So traditionally, when we have a vaccine, the timeline does take about 15 years. So it is a great question to ask, well, was it developed too quickly? And as you can see here, just with clinical trials, You do the research, and then there's 1 to 2 years for phase 1, and then 2 years for phase 2, and then a few years for phase 3, and then it goes through additional reviews before it makes it to the patient and the community. Well, what was different here is that the manufacturing began, and remember, we did the research before on this virus. Sorry, I'm going to go back on this virus, and the phase 1, 2, and 3 were actually combined within months. So it's not that they didn't happen, but they were fast tracked. And the FDA then approved and looked over with the CDC what was gained and learned from the trials, the phases. And then it went into production. Okay. So one of the questions that what I just reviewed answered the question about how did we sort of get to this point so quickly. But one of the main questions, important pieces is, well, what we give you, is it effective? And it's important to note that 43,000 patients were tested with the Pfizer vaccine through a clinical trial, and it found 95% efficacy or protection. And for the Moderna, 30,000 were tested with the protection or efficacy of 94.5%. Now, that's key. Majority of vaccines make about 50 or 60% efficacy. And so these really overshot, which is great. Now, as we know, most of us know, both vaccines come as 2 shots. And we're not going to talk about the J&J vaccine today because, as we know, it's put on hold. So we're going to focus on what we know for Pfizer and Moderna. Those are 2 shots. J&J was 1. And it's approved. The Pfizer is for people or individuals older than 16, and Moderna older than 18. So will this vaccine hurt my community? That's a great question. Will it hurt my community? And I point out to folks that actually a diverse scientific community came together to make these vaccines. And unlike a lot of clinical trials, we had a diverse population of patients who were represented in the clinical trials. Why should you get the vaccine? To protect yourself, to protect your family and your community. And really, we have to end this pandemic. So let's talk about health disparities in the COVID-19 vaccine, because that's why we are sort of here. We know that in the United States, actually, let's say globally, unfortunately, COVID has killed close to 3 million people. And when we look at the deaths in the United States, we are approaching 600,000. Well, what are health disparities? Health disparities are differences in the incidence, prevalence, and mortality and burden of diseases and other adverse health conditions that exist among specific population groups in the United States. And that's the NIH definition. So let's kind of dive into that a little bit. The best way that I can sort of explain it is by giving you some examples. When we look at the coronavirus, we know that nationwide, Black individuals died at a 1.4 times rate as you compare them to white people. And it's certainly multifactorial, but that is a disparity. That is an inequality, and it's something that we certainly cannot ignore. So what are some of the reasons why there's increased COVID-19 risk? Well, living conditions, I know in New York, we did a deep dive early on, and we're concerned as we were a city, a state that got hit initially, right? And because of living conditions, densely populated areas, lack of transportation, so the use of more public transportation, people being essential workers and having to go in when we did not have the proper PPE, we did not have the proper protection. They were unable to take sick leave, and unfortunately, they came in contact with coronavirus. Health circumstances really plays into socioeconomic status, the lack of insurance, underinsured, the need to seek medical care due to cost, and chronic conditions and comorbidities also, should be considered. And then, of course, we cannot ignore systemic inequalities. Systemic inequalities are huge. And in the medical field, unfortunately, we often blame patients, their socioeconomic status, et cetera, but the system was not set up to really protect and provide care for those individuals who are affected. And unfortunately, minorities saw the brunt of that. And when I talk about health disparities, I'll also talk about, in the same breath, social determinants of health, because they really play into the cause and effect of why we have poor health outcomes in certain patient populations. And social determinants are the conditions in which people live, work, learn, and play. Think about that. The conditions in which you live can affect your health. The conditions in which you work and play can affect your health. And when we look at racism can affect socioeconomic status. I can talk about that for days and how that exists. Environmental exposures that we are subjected to, we as in minority communities, stress because of the socioeconomic status. And you just open up the news and you see that, minorities and people of color are subjected to police brutality, for example. That can affect someone's health behaviors, access to health services, and access to testing and screening, which is key. A lot of minority communities did not have access to testing and screening, and as a point has led to poor health outcomes. An example, as you may or may not know, is in breast cancer. African American women are 40% more likely to die from a breast cancer diagnosis. And certainly this multifactorial. It has to do with tumor biology. It has to do with access. It has to do with other reasons, social determinants of health, but the disparities certainly exist. When we look at sort of the COVID-19 vaccine distribution and as it relates to race, we see that every state is different. And I know that we all are from different places across the country, which is beautiful. So we are diverse in the representation here in this webinar. But in the same respect, different states have vaccinated sort of better than others. And I just pulled vaccine distribution disparities as it relates to race for New York City. And as you can see, the 76% of those who are vaccinated were white, 10% were Black. And that doesn't add up when we talk about those who were most affected or become most affected by coronavirus. Now, I should make a point and statement here in that young people, now that the vaccine has rolled out, and older individuals have been vaccinated in certain respects, we are seeing an uprise of younger individuals who are unfortunately affected by COVID-19 and don't have or didn't have the access to the vaccine. And so as states open up and expand the criteria for obtaining the vaccine, we are encouraging young individuals to also get the vaccine so that we don't see that disparity. And then, so my final topic is the COVID-19 vaccine and breast cancer. And what I wanted to do was, I have patients who come in and they ask, should I get the vaccine? And as we learn more and more, and as we sort of reflect on what happened and continues to happen in our country as it relates to coronavirus, I cannot impress upon you in our community that it is so very important to at least consider getting the vaccine, but safely. The NCCN, which is the National Comprehensive Cancer Network, did make recommendations as it relates to vaccine distribution. And they say for cancer patients, they say that patients with active cancer and those on treatment should be prioritized for vaccination. And immunization is recommended for patients receiving active therapy. However, they do say that for those who receive cell transplantation, for example, or engineered cellular therapy, 3-month delay should be had before receiving vaccination. And then we also need to think about not just individuals who are survivors for cancer, but also their caregivers and people in their household so that they too are immunized. And as it relates to solid tumors, which breast would fall into this subcategory to the right, we see that if you're receiving cytotoxic chemotherapy, that the NCCN recommends that you receive the vaccine when it's available, which is now. Targeted therapies as well as immunotherapy. Also, there should be a discussion with your primary care your cancer specialist to determine the best timing. But we are recommending vaccination throughout the continuum of care for breast cancer, and especially for our survivors. What can I expect after getting the vaccine? Well, that's important. You may have arm pain, swelling at the injection site. That's normal. Other side effects include fatigue, muscle or joint aches, headache, chills, and less commonly fever, and especially after the second dose. So those are normal signs. And it really means that your body is building up that protection, that army that we talked about. Now, just because you get the COVID-19 vaccine does not mean that you will not have that exposure to coronavirus. It just means that if you have that exposure to coronavirus, your body is now equipped to fight it. And, continue to be vigilant. There is light at the end of the tunnel. But in the meantime, consider the vaccine, wash your hands, wear a mask, and watch your distance. Happy to take any questions.
Well, thank you so much, Dr. B, for that excellent presentation, insightful as well. And so I just would like to remind everyone that there is a Q&A box at the bottom right hand of your screen. That's where you can enter your questions, and we will try to get to as many questions as we can during this session. So one of the questions that was raised, Dr. B, what is the difference between health disparities and health inequities?
Yeah, the way that I like to look at disparities and inequalities, there's actually a nice picture that I wish I pulled up, but it's basically 3 children trying to climb a fence. And when you look at that picture, imagine a child who is, let's see, say 5 or 6 feet tall, right? And they don't need a boost up. And then you look at the next child who may have gotten a little step stool, but really can't reach the top of that fence. That's an inequality. And then you have another child who is maybe smaller, but has been given those stepping stools to reach the top of the fence. So when we look at that, we have to think about the framework, going back to social determinants of health, and how it has played in the systemic racism and sort of the I don't want to say the inequalities within minority communities, and how we have to make that right. And that means giving those stepping stools when they are needed, so that it's an even playing field for all.
Thank you for that. Yeah, that is the famous picture. So I do know the one that you're referencing.
Right.
Another question that we have, what do you see as the biggest health disparities in the COVID-19 transmission and infection?
So the biggest, that's a great question. The biggest disparities, I kind of briefly touched on it. And I actually wrote this up early in the pandemic when we talked as it relates to the infection, in that, we had so many people who were exposed because they were essential workers, for example, and did not have the opportunity to really receive the appropriate care or even testing for that matter. And unfortunately for the COVID virus, or the coronavirus, we have seen disparities and inequalities across from the very beginning, from infection to testing, right? Where testing wasn't available. And we know that that testing is important because there were people who would be carriers, right? And not necessarily have signs and symptoms. And as a result, may go visit grandma or be in the house as grandma. And then now grandma is affected. And I can't tell you, I actually have some people who I know who were just essential workers. And it wasn't like they were going and partying and doing all of that stuff, right? Just going to work. And unfortunately, contracted the virus, but didn't know it, and then passed it on to grandma. And then grandma now, unfortunately, has passed on, right? So there was a disparity in providing equal testing for all people. And then we see that disparity and inequality as it sort of translates to vaccine distribution, in that, we know that each state is different and the recommendations sort of change and they continue to change. But if you think about it, early on with vaccine distribution, we often say that as far as vaccines are concerned, that minority communities are hesitant. There's this vaccine hesitancy. And I will tell you that there is some truth to that, but it's not the whole truth. And, we cannot just sort of lie on that as being, an excuse. With education comes openness to receiving the vaccine, with admission that the reason why there is mistrust as it relates to vaccines are because of the issues that have happened to marginalized communities and underserved communities, for example, Tuskegee. And so addressing those and not pushing it under the rug has been important as we address COVID hesitancy. But for those patients who are interested in getting the vaccine, think about it. A lot of the vaccine distribution early on, and even currently, you have to go through digital means, right? You have to sign up, you have to wait. I know in Washington, D.C., where my family resides now, I'm in New York. Shout out to New York, Desiree. I will shout out New York, but D.C., for example, I had to reach out to the mayor and say, this is ridiculous. People are getting vaccines, but my grandparents are unable. They have been put on a wait list, and that's only because I signed them up. And so who is signing up these other, elders, and so we have to think about the digital divide and how that plays into unequal access.
No. Yeah. So true on so many levels.
Right.
There was another question, what do you believe are the biggest concerns you hear from communities of color regarding receiving the vaccine?
The biggest concerns as far as receiving, were kind of just, what I said, in that they don't have the same, I shouldn't say they don't have the same access, but the mechanism of getting it is not as, there's barriers in place, right? So who's going to sign them up? And some of these states, unfortunately, make it really difficult, where you have to sign up online, and that's the only way. And then that's just to be put on a list, and then that list is updated every week. And if you didn't get the email to come and get the vaccine, you gotta look for that email too, right? Then you gotta sign up again, and this is repetitive, process. So that's certainly, one way. But also, what about transportation and getting to these vaccines? I know that there were issues with access in New York, even, where in Brooklyn, there wasn't a center initially where patients in the community could really easily access or have access to the vaccine. And so they had to go to another borough. Well, if you're thinking about your 80-year-old grandmother, how does that work? One of the things with the J&J, and I know I said I wasn't going to talk about it, but the J&J vaccine is that it was a one, it is a one dose vaccine. And so there was some excitement about the ability to sort of decrease those barriers that exist for communities and populations. And so, you have to think about not just one shot, but 2 shots until the FDA determines whether J&J can continue to be distributed. So there are many barriers across the continuum as it relates to vaccine distribution, and patients I shouldn't say patients, but people will, have said that those barriers certainly exist within their families. Now, I will say that we won't talk politics either, but that our current government, I think they are really trying to address some of these inequalities. And so I'm encouraged that that will continue to not push it under the rug, but really, certainly address it.
No, understood. I guess a couple of things, you spoke about, clearly technology, being the barrier, also transportation. And so I'm thinking about the, young adults in our community who might be in active treatment.
Mhm.
Do you know whether or not, and yes, we have people around, the country, but do you know whether or not those individuals can actually, get the vaccine when they come in for treatment? Is there a special system set up for those individuals versus going through the city and state process?
That's a great question, Desiree. And I will say from our institution standpoint, we have made it easier for patients who are receiving treatment, because you're right. If you're in a healthcare system, priority should be given to you. And in most places, I know that they are striving to provide that care. And so, because we all are in different states, I would say reach out to the hospital system that you are being treated, and see if they have a mechanism in place, because that would be certainly most ideal, and could sort of improve your access to these vaccines. Um, yeah, it just really depends on the place. And I know that there's a hospital system not associated with us where, again, I talk about my family because I am human, and I think that, it's important for us to relate it back to real life, and compare and figure out how we can do better, where my mother has been on the list for, 4 months now. Wow. I had to go through a community, system to get her vaccinated. And so not everybody has figured it out, unfortunately.
Yeah, no, yeah. Sadly, but we have to continue to press on,
We absolutely have
and be vigilant for sure. I guess I would also, inquire for those, who are no longer in what would be considered active, treatment. Let's say, for example, can you speak to if there's an individual who tends to have allergies? Or sensitivity to different, pharmacological drugs. Is there something that they need to think about or talk to their doctor about in preparation for the vaccine?
Right. So actually, I'm going to break that down into two answers, because I think you touched on two important parts, or pieces. So for those who are not in active treatment, meaning you are a survivor, right? Survivorship program. This is an important sort of community, right? And so it's important to talk to your clinicians and your survivorship team to determine, if you haven't gotten the vaccine, best ways of receiving that vaccine. And I say that because we have a mechanism in place where when vaccines become available for a hospital, we actually reach out to our community of women and men and say, listen, we have this vaccine available. If you are willing to come in during your next visit, we can, especially if it's in the next week or so, we can give you that vaccine. As far as allergies are concerned, it is recommended that if you have severe allergies or you've had reactions to other vaccines, that you have a conversation with your primary care. And what they can do is actually provide you with pre-treatment prior to the vaccine, like, for example, steroids, to prep your body from sort of reacting to the reagents. We haven't heard much in the way as far as allergic reactions, but again, everybody is different, especially if you are hypersensitive. There are things that your physician can do to equip your body and get you ready so that you still are able to receive the vaccine.
Okay, that's helpful. There was another question. How can we help with end health inequities? And so, what role can patients play to ensure equal access to health care? What are your thoughts on that?
That's a great question. I think that I'm going to answer it in a roundabout way, in that I like to put the onus initially on the system, and take ownership as a system, as a healthcare system, because there are lots of wrongs that we need to make right. One of the things that I essentially address in everything that I do is implicit bias, and how it has hurt the care of people, minorities. And that implicit bias is embedded in the systemic racism that exists within our community. And so I think it's up to providers initially to call a spade and say that implicit bias exists, period. And then to figure out ways to work out those implicit biases that exist. We all have biases. Let me be very clear. I have biases that I have to constantly check myself on, to be clear, right? But I'm working on it. And I think that is what we have to ask of the medical community, is to work on those implicit biases. I'll give you an example. And Desiree, we've talked about this before, and I'm actually going to be asking your help and assistance in this clinical trial accrual, okay? And one of the things that we have done that I've rolled out as a program is we often constantly hear that, just for example, breast cancer clinical trials, Black women are underrepresented in clinical trials. And it is a real thing. And again, we can look at patient factors, mistrust and that sort of thing. But when you put the onus on the system and look at really, were those clinical trials introduced, you'll find that they weren't. You will find that if they were glossed over. And you will find that the reason that they weren't introduced, or whether they were glossed over, was because that physician had implicit biases that assumed that that person wasn't going to agree to the clinical trial, or that they had access issues. And so maybe they can't come to all of these appointments. And so I'm not going to introduce it. And that is the wrong approach. And so one of the things that we did was we took the onus off of just an individual, right? Because it's difficult to change a system. It's difficult to change a mindset. I mean, you work on it, you call a spade, you educate, you do seminars, you do all of those things. But one of the things, and so this is my roundabout for patients, is, what we have tried to do is put power in your hands to empower you. So when my navigators have the initial conversation with newly diagnosed breast cancer patients, they introduce, you have an opportunity to participate in a clinical trial, to every patient, right? And then we have our clinical trial members in the clinic, and they help us identify those patients who are candidates for certain clinical trials, regardless of their socioeconomic status, regardless of, whatever issues they may or may not have. We also discuss it in tumor board sort of blindly, even before we necessarily meet the patients. And then those patients are given the opportunity to participate in those clinical trials. And what we have seen is that number has gone exponentially up, and particularly within the Black community and a Hispanic community. So when you empower someone with the knowledge that they need to make their decision, and you take away the systemic implicit biases due to systemic racism, we are able to, sort of overcome that. So as just as people, right, it's important to seek that education, but also to challenge your clinicians to educate you, and to just challenge them, ask questions. And if you cannot relate, or you're not comfortable with your clinicians, maybe time to look for another.
No, that's you. Yeah. Well, you're speaking my language, right?
I know. Want to wheel you in a little bit.
Indeed. I'm really excited to hear, the process that you've spoken about in terms of the clinical trial piece. And I would add, I know we're talking in terms of breast cancer research, but I would just ask you if in terms of the clinical trials that were done for Pfizer and Moderna, do you know how many young adults or young adults with cancer participated in those trials?
Yeah, so I don't have that info.
Okay.
I had it I had it before because
Yes.
we were looking at it, but I can get that info and send it, to you. I was going to say something because I thought you were going to go another way, but that's a very important question as it relates to young individuals and in clinical trials in Pfizer.
Yeah, yeah. I think, one of the things that's, important to your point about clinical trials, we really need to find, mechanisms in order to help to inform individuals why participation in clinical trials, or in research is important. And so, as you talked about, the work that you're doing, I definitely, was just thinking in terms of, how many did participate, in the trials, that have currently occurred as it relates to both vaccines.
Absolutely. There's a great chart and I will send it to you, but I also will use this opportunity to talk about the what we did at in our hospital system to address vaccine sort of hesitancy for all individuals, young and old. And we sort of did this about maybe 3 months ago. What we did was, I think, novel in thinking outside the box. When the vaccine was available to hospital employed individuals, we noticed that in Brooklyn, our vaccination numbers were low,
Mm.
and there was conversations about what that all meant. And really, we have a very diverse makeup of employees, and these are people who, for example, you have the nursing staff, you have the the folks who are in the cafeteria, and the maintenance folks. And so, we had to figure out ways to really address it. And what we did was these sort of roundtable discussions where we would go and round, I should say, we would go round on different floors in different units, and we would address mistrust, and we would address, why COVID hesitancy exists, and we would educate, right? So some of the stuff that I talked about today, the vaccine and how it was, how it came to be so quickly, we addressed some of the myths and some of the facts. And oh, by the way, there are lots of myths out there, right? Especially within our community. And I related it back to some family members who, said, well, it's going to take over my DNA, and that's not true. Or, they're 5G. I mean, they're all different types of,
Yeah, we could be here all day and night if we go into all the myths, for sure.
Conspiracy theories, right? But I mentioned this, and I'm relating it back to your question about young individuals, because social media has been a help, but has also been a hindrance as it relates to, sort of getting the word out for the COVID vaccine, because you do have a lot of opinions and that are not factual. And so, but the vaccine, the trials were represented, thankfully. And so you can rely on those numbers. And I always say, numbers don't lie. So, so you have to look at, I think, research and really look at the data. What does the data say? And so that's how I'll sort of address that.
Yeah, no, thank you for that. Speaking of that, you've talked about, educating ourselves. You talked about, trying to be empowered. One of the things, and clearly, you can't be lengthy in terms, or would be a lengthy response potentially. But if you could just touch on how can people actually know how to discern what they're reading in terms of, is it evidence based, or is it potentially conspiracy? Because I think that oftentimes, you had given us, that chart earlier in terms of, the participants and the efficacy, et cetera. But if you have a community that has not really participated in research before, and are not as familiar, would they be equipped to really be able to understand what they should be looking for to have a comfort or increase their comfort level?
That's a great question. And you're right. We can talk about it, even within, again, I always say it's important to relate back to your personal experiences. Even within my family, I knew that that the decision that I made for receiving the vaccine early on, because I had the opportunity well before most folks as a physician, would affect my family. And so I'll be clear. I did my own research. I looked at the numbers. I didn't rely on CNN and some of these other, I looked at the numbers for Pfizer and Moderna and made a personal decision that for me to receive the vaccine. But in that, I have had conversations with family and friends who are still hesitant. And you're right. It's how do we direct them to know this is from a viable source versus, this is not from a viable source. And the way that I would sort of answer this is you go to physicians who have gone through extensive training to seek, advice about your care. And in the same respect, when it comes to the vaccine, I would recommend that we all be as vigilant and we look at credentials. And if we're listening to someone, do they have the credentials to really speak on it? Because unfortunately, what we are seeing in our community are people and even celebrities are speaking on this vaccine without, they don't have, and I shouldn't say credentials are everything, they're not, but if you're looking to have an expert opinion to really break down the numbers and explain to you, you want to get somebody who has been doing this is not their first rodeo, and doing it. And so that is my piece of advice for all people. And in the community, I'm not the only physician of color who is passionate about this, right? There are a number of physicians who recognize, again, you see the disparities that existed with us dying, literally, just families ravished. And so our passion comes from wanting to prevent that further detrimental impact within the community. And so you have a number of physicians and researchers and people who are well equipped to speak on the vaccine, who are out there in the community, engaging the community, doing talks, and so that's who I would listen to.
No, thank you for that. I'm just going to pivot a minute to another. You mentioned something earlier, and so I think this question touches on it. How does racial trauma impact both the individual and community's health?
Significantly. Racial trauma is a real thing, and I think as we continue to shed light on what we knew or know within our community that has existed as it relates to racism and the trauma that sort of follows, it absolutely can affect and has affected the community in ways that, will take time to repair. We always say mistrust mistrust is something that you cannot, you can't just brush under under a pillow and just say, oh, it's just mistrust. It absolutely can affect one's decision to seek care. It can absolutely affect one's decision to proceed and continue throughout their care continuum. And this is as it relates to breast cancer, as it relates to other cancers, as it relates to other comorbidities like diabetes, hypertension. It extends, right? Racial trauma, the psychological manifestations of that. We know that psychological stress can increase one's risk of hypertension, for example, anxiety, depression. And that can then it's sort of a domino effect, can affect your way in which you deal with, those diagnoses and whether you really follow through with treatment. So as a country, we have to more thoroughly address racial trauma in the context of being in this country as a minority, and figure out ways in which we can provide that support for individuals.
And so I just would, follow up to say, yes, we're here, as a breast cancer organization, but we all, have, friends and loved ones, etc. Can you share how should a individual prepare for a doctor's appointment in terms of, if it's your initial consultation, or you've been going to a doctor for a while? How do you talk to your doctor to let them know what you're experiencing, to see potentially for them to have a bigger picture as to, what some of the symptoms you're presenting, what it could potentially relate to? And on the other side, as a physician, are there certain questions you probe your patients in order to get an understanding of, what's going on in their world, and not just necessarily focus on the breast cancer specifically?
Yeah, great. So I'm glad you brought that up. As it relates to breast cancer, when you're initially diagnosed, I encourage all patients to, and this is before COVID, but to bring someone with you who can be your eyes and your ears and your support. You have no idea, when I talk about implicit bias, the biases start from, unfortunately, the very beginning. And clinicians tend to perk up and pay a little bit more attention when you have a support system. That's unfortunate, but it's true. So so having that support, and then as far as preparing for it, I love .org websites as you read and sort of educate yourself. Dr. Google is not great for breast cancer, meaning don't type in, I have breast cancer, what does this mean? Because everybody's story, as you all know, is not the same. You have some similarities, but everybody's path is different. And it's difficult to decipher that when you're newly diagnosed and you don't understand the difference. For example, ER/PR positive, HER2, So American Cancer Society is great. I know, Desiree, you may have some other sort of sites, but all of the .orgs are pretty legit. So educating, right, is important, and sort of understanding what your options are as best as you can before you even get there. Now that may be difficult, and so only if you are sort of looking to add to that knowledge. And then there was a second follow-up question that I thought was really good, and now it slipped my mind. Desiree, what you asked me?
Oh, yeah, no, I was just basically, inquiring, as it relates to, individuals, because, oftentimes when you go to the doctor, they're just there about, why are you here? But they never really ask you enough about, what's going on in your life to see whether or not that ties in. So I was asking you,
Yep, I got you. So one of the things that I do, and I think it's important as you go see your doctors, to see if you connect, right? And it's a little more difficult to do in the era of telemedicine, but I try to, the demeanor, I look in patients' eyes and, I sit and I'm not overshadowing, and I try to get the vibe of, are they understanding what I'm saying? And then based on that, we will probe a little bit more. Well, what do you do for a living? And what support do you have? And, so I think that those are important, absolutely important questions to ask patients who come, because you're right, going back to social determinants of health, it's not just the snapshot of folks being in the office. It's really the environment in which they live and they work, that can help determine their outcomes. And then I know that there was a question just about being an ally. I think, as an ally, we have learned over the past year, with all of the racial insensitivities that exist, that the best allies are those who educate themselves, and who do not require people of color to do so. But when people of color, when we are ready to educate, you listen and you understand our experiences, or you try to understand our experiences. And probably most important, you speak up. You speak up when you are in a room with other people who look like you, and perhaps they are saying something that is incorrect, or it can be perceived as racism, and you correct it. Because that is the best impact that you can sort of make. If you see that racism exists, or inequalities in care exist, speak up on it, because oftentimes you can sort of convince people within your own race and ethnicity more than we can, and provide us that support. Don't be judgy. If we say that something made us feel bad, or we felt like we didn't get the same care, it's not your place to either confirm or deny that, but to provide us that support.
Well, Dr. B, as always, I'm always happy to hang out with you.
Likewise.
I'm always happy to hear your words of both encouragement, inspiration, as well as just speaking the truth. So, on behalf of Young Survival Coalition, I just would like to say thank you. Thank you so much for giving of your time and serving as an expert speaker with us today. I would just like to remind the audience that we will have the survey that we hope that you will complete. I also want to say that if you're interested in any other YSC programs and support, including our upcoming virtual summit in May, you should visit youngsurvival.org. And so I just would like to thank each of you for being with us this afternoon, and hope that the information you've received have left you informed and empowered. Have a wonderful afternoon, evening, and weekend. Thank you so much.